in the interest of time, just a quick side note, the call is being recorded. And so I think in the interest of time, I think we should get going. If somebody joins us later, maybe we can give everybody a chance to introduce them. Since we will have a call with fewer participants given the summer month, maybe we can go quickly going around to introduce ourselves, and maybe we can do this person by person very quickly. I am Clement Steinberg. I'm one of the faculty for the HIV Continuum of Care, and I'm glad to have you on the call today. Who else wants to go next?
Hi, this is Trish Howard and Jen Hawks from Northern Health. Thank you.
It's Heather Winnichuk with the Stop HIV team in Fraser Health.
Ilana Canigan in Victoria with the First Nations Health Authority.
Jonathan Edwin with the Stop HIV team at Fraser Health.
And Ruth Hellerud-Brown with the Stop HIV team at Fraser Health.
And Kathy Wall with Fraser Health, bloodborne pathogen nurse team.
And the Positive Health team, Val, Rob, Sunny, and Shayla.
Hey, this is Christina Clark with the Collaborative.
Did you miss anybody?
Jennifer May Hadford with Interior.
Okay. First of all, a warm welcome to all of you. I am Clement Steinberg, and I'm one of the faculty members of the HIV Care Continuum Collaborative, led by the PC Center for Excellence. And this really initiative is made possible by the really hard work and passion of all the health authorities involved and many communities across the British Columbia. This is I'm happy to facilitate this call, which is our 7th in the series of 12 monthly coaching calls, and we will continue this call till January 2015. It's really important to me to engage you in this call, and we will encourage you to let us know. This is a more intimate call, so you have two venues. One is, which I propose to you, any questions you have, comments, additional thoughts, I encourage you to use the chat room on the lower right to add your questions, comments. For today's call, we really want to explore what it takes to create win-win partnerships. And we know that these partnerships are really necessary to improve HIV care. And we really want to hear, and we have two wonderful examples about creating partnerships, and we want to really explore what we can learn from them. And what partnerships have been important to reach your improvement aims. We also wanted to explore what additional partnerships are still needed that you're currently thinking about but have not engaged yet. And then also we wanted to explore in this call some useful idea and practical concepts to really build sustainable long-term partnerships. I have the great pleasure to have co-presenters on this call, and you will hear them later on the call, and I will ask them to introduce them, but I wanted to take a moment to thank them for some very engaging calls to get ready for this particular webinar, and I want to thank them for their contributions and letting us know what they have learned along their quality improvement journey. Here's our agenda. We are probably diving into setting the stage in a second. What is a win-win partnership and what's the framework for it? And I want to share some thoughts about that. And then we're going to have two presentations. We have one by Northern Health and then by Fraser Health. And you hear, and hopefully we can relate some of the frameworks we'll introduce in a second and how it's going to be applied in the real world. And at the very end, we will open it up also to your suggestions and things that you have learned along the way. And shortly before the end of the call, I also want to turn it back to Christina if there are some collaborative updates to share for our collaborative. The first one I wanted to do is to give you a very practical definition of partnership as it relates to this very specific call. Because partnership, the word itself, would probably means a lot of different things for different people. But for the purpose of this call today, we thought about a partnership as an established process of two or more parties. They could be external or internal to your organization with mutual benefit to improve HIV care. I think there are key words in there. One is the word established. It's not something that just happens, but something that is established, meaning there is a framework and expectations, roles and responsibility are established. And the partnership activities include the exchange of information, but also resources. And when I use the word resource, it's not necessarily dollars, but also could be time and staffing to benefit people living with HIV. The purpose of this partnership is really to accomplish the aims of our collaborative. And while there may be a lot of other partnerships that could be financial or otherwise in nature, we're really focusing on the efforts for our collaborative aims. This is a game that I usually play. So since we are not in person, but rather virtual, I quickly would tell you about this game and what it is a one-on-one game. So you would find a partner. You would stand across of each other, and there would be a line between you. So you'd face each other, a line between you. And what the objective of this game is that within 15 seconds, you have to convince the other person opposite of you to cross that line. And whoever crosses first wins. Okay, so this would be the setup for this very simple game. And I tell you, when I play this, usually a few things happen. A, you're not allowed to pull somebody over to your side, so you have to verbally try to convince the other side. But I would think about 50 to 60% of the time, nothing changes. One side argues to the other ones. You come over, I give you a granola bar, I give you this, I give you that. Bribing is usually part of it. But so in most cases, nothing changes. In about, I would say, 2 in 10, they change at the same time, and the rest, maybe one person goes first. This game, I think, illustrates one very important lesson, that winning often is defined as if one side wins, it means that the other side has to lose. In other words, I have to convince them, but that means I win, you lose. But the reality is that both parties could have won in this very simple game by crossing the line at the same time. And some teams do that, so that's usually 1 or 2 out of 10 who basically shake hands and cross at the same time. I think it really illustrates that often it's set up as my own interests, which is I'm winning, you are losing, are in conflict with the common interest, which basically we both win. So when we think about partnerships, that lesson learned should be applied, that we are all thinking about, when we think about partnership, it means that both sides win, and therefore setting up win-win partnerships. Setting up a partnership and make it successful does not mean I win, I get all the information, I got all the benefits, and the other party doesn't. It's a mutually agreed process by which both sides, for the mutual benefit, are engaging. The second thing I wanted to quickly start out with is and you've seen this many times over, with our HIV care continuum. We have learned through this care continuum that we know that each silo, whether it is a testing site, ambulatory care program, are doing pretty well. But I think that across the entire continuum, I think we have often realized system failures to effectively serve our patients. And in other words, in order to do better along the continuum means that you have to engage others in your own processes. A single provider, as somebody once told me, a single provider cannot single-handedly improve HIV care, given the complexity of HIV care. but new partnerships are needed. If I'm an HIV testing site, I rely on the HIV care program to engage the patient and maintain them in care. If I am an outreach program, I need to find the partnership with the care, and also the HIV care program needs the partnership with the outreach program to benefit the patients. I think we are reminded through the care continuum that these partnerships is probably a very new component and a very critical one, and one that we hope is one of the outcomes of our initiative. So I have one question for you, and I would like you to think about the following question, and we hope that you can put the response into the chat room on the lower right. What partnership, or ships for that matter, have you established since the beginning of the collaborative? So I would like you to type in the name of both parties. For instance, not so much the name, but more so this was, we have now, for instance, a testing site and an HIV care program. Or for instance, the HIV outpatient program with a referral site. Or an ER with the HIV care program. I would love you to quickly type it in because I would love to see what partnerships you have established, and so we can see a little bit what's going on. I see several people already typing. Let's see already what came out here. I see from Sheila there is the PHS and the Keys and the Aboriginal outreach worker. Wonderful. Let's see what other ones come in. While we're still typing, maybe I give you another question to consider, and then we can see all those things together. So when you have established your partnership, in your opinion, what are the most important ingredients, step, or tool to develop a win-win partnership? So this is really a question to all of you. So maybe you can give us one lesson learned from your experience about to develop and sustain a win-win partnership. What would be the one thing? So it would be great to hear a few suggestions from you. So Christina puts out mutual respect. I want to hear a few more. Communication. Now I hear from several parties now the word communication. The open flow of information going both ways. Jonathan puts out the listening and also flexibility. Okay. Thank you for sharing. So this is a win-win partnership grid that we developed as a way to formulate about what it takes to create those. And so we want to go through those a little bit, and we're going to hear after that one of the examples of creating a partnership and their lessons learned and how it applies to this very partnership grid. So I want to quickly go through them. The first one is about that it has to be agreed upon aim with established goals. And it means that all parties have to align their goals for a mutual aim. So it is that both parties or more have agreed to it, and they have established this aim together. The second one is that it is a formalized relationship with clear roles and responsibility. It is in writing about what each party will contribute, whether that's resources, allocation that could be either done through an MOU or any other way, but it's very clear about what the responsibilities are for both parties. The third component is the routine communication flow. That is, not only there could be meetings, calls, in-person interactions, and so on and so forth, but it's a bilateral exchange of communication. That is, could be the listening and learning from each other. That is not just a random act when we need something, but it's set up in a way that proactively schedules those communication flows. Exchange of information. something where both parties are contributing the information. That could be information, could be the medical record, it could be data, it could be performance data or any other. But it's the agreement that both parties are sharing. Often a partnership is that one side gives the data to one party, but then the other one is not. So it's really a bilateral exchange. And lastly, it's that the measurable assessment of its outcome. In other words, that both parties know when we are successful, what that success looks like. And that could be measured by the number of referrals, the number of patients being transferred, the number of any interactions. But both parties know that when we do this right, that we can actually quantify the success. We will hear more about this grid in a second, and so I would love to turn it over to our first example from Northern Health. And again, I want to thank Patricia, Jen, and Sam for sharing their story. And I don't know, Patricia, are you talking first?
Yeah, I will start.
Okay, wonderful. Go ahead. Thank you.
Okay, thanks for this opportunity, Clement. So we're here in Northern Health as part of the bloodborne pathogens team. And so we've been working on the acute care rollout of the routine offering of testing. And in order to have that, we've also have to engage the community. So that's where we've been readily involved right now. And the last community that we've been working really closely with is in Burns Lake. And that's a picture right there that's representing the new hospital that's being built, and a picture of our team there as well. Next slide. So what we've been doing here is we've been really working on our steps to build our partnerships. And what that looks like is there's been an alignment with Sam, who's been going into the acute care setting. And so what we did was, once he had received his dates with the leads in Burns Lake, we wanted to make sure that we were right alongside him. So as a result of him being given the date in August, I began to work with the communities and the key stakeholders within Burns Lake region to identify who those strategic partners would be, and the potential HIV testing sites and staff that would be involved in this rollout. So we began to create a database for the current state of the HIV services, so identify what was there and what wasn't there, and we did that. Can you go to the next slide? We did that with our step, the environmental scan, and what that environmental scan looked like, we actually borrowed it from Megan Chuma, shared that with us, and then we adapted for what we needed in our region. So there's like 30 questions on this environmental scan. So as we were working with the communities and the different organizations, letting them know that we were coming there and offering the routine testing of the HIV, we asked them if we could conduct a pre-visit environmental scan. Now, we've done this in a few different communities along the way. So Sam has been to Vanderhoof, Fort St. James, Fraser Lake, and now Burns Lake. And these environmental scans have proved to be pivotal. While we did learn through the first couple of times that while we were trying to elicit the responses of the people via emails and stuff, that just really wasn't working. But the research has shown that people don't respond to the emails as well as they do via either a face-to-face or a telephone conversation. So as a result of that, we've changed the way we administer them. So when possible, we try to do a face-to-face, and otherwise we do pick up the phone and do the engagement piece, building the relationship that way. And so we've been working really hard building these relationships and letting people know what the objectives are with the provincial From Hope to Health goals and how it lines up within Northern Health, and ask them if they would mind doing this pre-visit scan. So we took all the results of those questions and filled out the scans, and on the bottom of that page there is an example. So while I was in Burns Lake, I was speaking with 9 different communities or organizations, so whether it be public health or a First Nations community or the Elizabeth Fry Shelter or whatever, these are the results that came about that, so we pulled those out. And as we were speaking with the people getting the results of the environmental scan, we asked if they could also identify some other key stakeholders to make sure that everybody in that region was also included. So while we had that going on, then I would share the results of their environmental scans back with them so that they could approve that and make sure that's what they wanted to incorporate and include. When we also did have those results, I have forwarded a few of them on to the First Nations Health Authority and the public health within the Northern Health Region and the First Nations Health Authority to ensure that they would know what was kind of taking place in that area with all the identifiers removed, so they wouldn't be able to know who was saying what information, so we could protect that anonymity. And then we worked towards having our focus group, which we did conduct on the 12th of August. And out of that, we had approximately, if you don't mind going to the next slide there, Clemens. So we, out of all the people that we tried to include, which is listed in the detail below, we had about 50% attendance, which we thought was pretty good considering it was the middle of the summer, as well as trying to actively engage the different communities. So what we did for the agreed upon goals was to basically what we wanted to let them know that this was going to be done respectfully and in a way that's going to incorporate where they're at in their communities in alignment, and we would be there to offer our supports and services. And then also to identify the other key stakeholders in that communities who would be available for support to one another. And as you can see, this is the list that we included with that. So next slide. So for our routine communication flow, we've been doing ongoing meetings, and that was actually one of the biggest things that was discussed while we were there was there was a level of support that they want to have. Their first goal that was identified was that they wanted to have ongoing meetings with educational as a component. And the other thing that emerged was the need for harm reduction. And so we're beginning to work with public health in that capacity to ensure that that is covered there. And what they really want to see there, because I wanted to work with them to identify what their top 3 priorities would be in order to have this in place for them. And the last thing that they determined was that they needed to have normalized testing and to have that reduction of stigma. They identified stigma as being a big barrier for them there. So we've determined as a result of all of this information that they need a little more support. So we're going to have another meeting in October, and we're going to have all the leads in place, and the public health is going to be coming with us to ensure that these areas that they've identified as concerns can be addressed in a larger capacity. The last slide, please. So Jen's just going to take over and talk about the lessons learned, because she was there with me during this this focus group and was the one that was capturing all of the thoughts and ideas that were coming forward as well.
So we did learn that the best communication takes place either face-to-face or phone calls, and the written communication wasn't as effective, and that it needed, each action item needed to be followed up, and so we had to follow up to get people to attend the meeting, and then we have to follow up with people to get them to attend the next meeting and continue to take steps towards building the partnership. The community did identify that there was an overlap of services, that there was a lot of services, but some people were doing the same things. So communication between organizations is key, and just even getting together so that everyone knows what everyone else can do, and that the senior leadership, such as the managers, the chief and council, the physicians, they needed to be included because some people were feeling that they couldn't take the steps that they wanted to because that wasn't supported already by their leadership, and if their leadership could establish like what actually was a role and responsibility that they could add to what they were doing to incorporate these new objectives to their roles is helpful. And there's a lot more education required before some of these steps can take place as well.
So actually, Clemens, while we were in there, we asked even, so there was RNs in there, there was health directors, there was like a variety of levels of professionals that were in that room, and we spoke just even the very basics and asked if they knew what the, what the transmission of HIV was and what the 5 fluids were. And there was even confusion amongst that. So the level of education needs to be really brought up and over there.
Mm-hmm. Mm-hmm. Well, first of all, thank you so much for sharing your very intriguing story, and you also have very beautiful slides, and the drawings are just phenomenal. So we have a few minutes. Maybe we can open it up to our participants on the call if you have any questions about what you heard. And you have 2 options. One, if you just speak up, and you can also put your questions, comment in the chat room as a way to do that. I have, do we have any questions from the floor? I have a few questions for you, but I don't want to take up the floor too much. Any questions? You can actually speak up since we have a smaller number of individuals today. I see a few comments about what folks heard. Can I ask in the meantime, while we are waiting for a question, you pointed out that the community readiness is really essential, and I think that's really important. Have you encountered any resistance along this process? And if so, how did you overcome that kind of early form of resistance? Do you have any advice for us?
I think that a lot of the resistance comes from a combination of lack of education and fear, and such as like some of the community members being very, like if they work in mental health, they'd be worried about telling someone to get screened because what if they came back positive, and how would they support them, and so just learning more about I think the process of what happens when someone is diagnosed as positive and how do they find out, and it's not their role to tell them their positive results. It's their role to be there as a support and guide them towards care and keep them in care, but not necessarily be the ones taking the lead in that care, I think. And then the confidentiality in communities, especially small communities, is, I don't know how we're ever going to overcome that barrier, other than stigma reduction. Yeah, any ideas? It says any ideas on how to reduce stigma, and I think that comes from the education, and just kind of everyone being aware of what is HIV, how is it transmitted, what is risky situations and what is not risky situations, and then knowing that there is treatment, and treatment improves survival and also prevents transmission. So it's important for multiple reasons. And do you have any other ideas? Well, I think
One more
sorry,
question. I didn't want to interrupt you, but there's one more question about what most surprised you about what you have learned along your journey.
It was kind of surprising and not surprising, I think, the level of knowledge that there was, because there was even an RN that
said that she thought that HIV could be transmitted through tears. And that kind of took me back. I was really surprised by that because I think that alludes to the level of fear and resistance that's currently in place because of the lack of knowledge and that information about how that actually occurs now.
There's one more question that posted in the chat room about will there be ongoing meetings amongst the Burns Lake stakeholders without the team organizing them?
And that's what we're currently in place for, because I kept on reiterating to them throughout that focus group that we are here as supporters, as a supporting role. We aren't here to take this on and to do this for you, but we will be there. You know, if we don't have the answer to a question, we'll find out for you. We will connect you with who needs, you know, who has those answers for you, who can provide that information and support for you. But at the same time, we also recognized that there would be a little bit more of a supportive role initially. So what I've been doing since we've come home from this focus group since August 12th is I have contacted the public health lead, and I've also contacted a few other people and asked them to, the lead of the Curious-Sakani Family Services, and asked them to identify who would be one of the key stakeholders. So I wanted to have a kind of a joint partnership between the different organizations to ensure that those community champions that were identified would be able to do the next steps. So what we're doing is we are organizing this for that, and then to identify those champions, and then so do that in a supporting fashion there. And that's why we said we need to have the leads available, because one of them was a frontline worker, and she wants to do this wellness van. She wants to do some needle exchange, stuff like that, but she doesn't know if it fit within her job description and her scope. So by having those leads available, they would be able to go, yes, you can do that, or this is what it's going to comprise of. And so that's what we're working towards right now, is literally handing that off to them and being there in a supporting role.
Wonderful. Again, I want to thank you. This was a very intriguing presentation. I particularly enjoyed hearing about your, really the environmental scan that you did. Is that those questions that you used, you mentioned the 30 questions, are those available, and could those be shared?
Absolutely, we can share that, and if you wanted to, I could probably even share the ones that were compiled from Burns Lake and have, like I said, the identifiers removed so that nobody would be outed there. So yeah, I can share that with you. I'll email it forward to
That would
you.
be fantastic. I think in the way you approach is being very, very broad and really try to be, really try to get a broad perspective, and I think it's really very commendable. So thanks so much and thanks again for your incredible hard work there. We want to hear another story about building partnerships, and I'm going to turn it over to Kathy. I think you will start out the next presentation. And now a quick reminder for everybody, if you have any questions, comments throughout the presentations, please just put the question in the chat room. So once we are done with their presentation, we have a little time for engaging our presenters in a dialogue. Kathy?
Okay, thank you. And thank you to Northern Health. That was a great presentation. So I guess this is just our first slide, and maybe we can go to the next slide. I'm a public health nurse in Fraser Health, and Jonathan is a coordinator for our Stop HIV team. This is our team here, and it's public health nurse. This is a public health nurse team, so actually we're missing a few. We have public health nurses that are basically specifically bloodborne pathogen nurses, and we do HIV reportability, community outreach, and case management. We have 4 in Fraser North and 4 in Fraser South and 2 in Fraser East of the nurses, as well as other managers and other members of the team. So our project this year has been in an effort to re-engage those HIV patients who've been lost to follow-up. We formed a plan to more intentionally develop collaboration with 3 of the main HIV treating physicians in Fraser East, between Fraser East physicians and the Fraser East bloodborne pathogen nurses. So that's where this little circle, the crossover, the circles combines in there. So it's sort of a blending of the public health and treatment, which is sort of a new area. And it was chosen to be in Fraser East because that was shown the greatest percentage of loss and retention of care on the cascade of care from the BC monitoring report as compared to Fraser North and South. So because we've had significant involvement and rapport with these physicians previously, and there were only a few, it wasn't difficult to approach them to inquire about meeting to discuss more formal plans to work together. The physicians all had concerns about patients that they had seen previously but haven't seen for a long period of time and didn't know if they were still receiving care or not. They didn't have the time to follow up or track these patients down and continue to be a concern for them. And some of them, in fact, the physicians are still writing, renewing prescriptions even though they haven't seen them, but they don't want to stop their treatment. So this is also the group that we wanted to attempt to re-engage with, and that was the common goal that brought us together. The collaborative helped to provide the framework, so the data, some of the formulas from which to base our goals and our baseline work. So proposal was made for patient re-engagement, and we, including the formulas of, population of focus and all those ones that were on the collaborative. So we arranged meetings with the doctors individually at a location of their choice and according to their schedule. So we met them face-to-face. And we'd been given direction or approval from our management that we could meet at the physician's offices and, as part of the plan, even offer some time for a public health nurse to spend in the office to work on the re-engagement if that was necessary. And we were positively received with each of these offices and doctors. The plan was presented as a draft collaborative plan, which was open to changes according to each physician's needs. And it was clear when we presented the plan that it was a Fraser Health collaborative plan to work locally with physicians interested in re-engagement of clients and not simply a study that's looking for their input without receiving anything back. And we found each physician had varying needs and strengths that brought the collaborative work. So it also included a little bit of education about the role of the public health nurse and the specific role about this plan linked into care. So we laid out clear responsibilities of what the role that the nurse could and couldn't do. We listened to their concerns and adapted the plan as we agreed upon. So we kind of took their feedback. And communication was done back and forth with the physicians through phone calls, and it continues to be used through phone calls, emails, even office visits, and it continues to be so. And some examples of how things that have come out of that are one of the ID specialists has given permission for us to make direct referrals to him for follow-up if a patient doesn't have a GP and is in need of HIV care, because we see we get a report of all the new diagnosis cases of HIV sometimes before anybody else does, and doctors locally don't really know where to go necessarily or which doctors are serving them. So in this area. Another outcome has been that 2 of the physicians have given us lists of their patients that they haven't seen in the past 3 years and are wondering where they are. And we've made an agreement about how they've given us approval to attempt to find them or find out if they're still linked to care somewhere else. One of the physicians called last week to discuss a new client that disclosed a contact, and the physician felt he needed to contact us, so he contacted me about that. So we feel that those are really good measurable outcomes to show that there actually is a bilateral exchange and a working relationship. And one of the ID specialists is planning to do a grand rounds presentation in collaboration with our MHO from our STOP team. And of course, with the confidentiality, we discussed the confidentiality and used the partner notification best standard practices from the BC-CfE policy as our agreement for exchanging names and that kind of thing, because that was a bit of an issue with the docs. But because we are HIV nurses who get care, names right away, we had an agreement there that we could use. And then the other thing is just an addendum to that is trying to establish this list of patients that are lost to care, we needed to determine from the list if they've moved or if they're getting care elsewhere or they're just lost. And so that's been a bit of a challenge too. And so one of the ways that we're working on is through the Center for Excellence as they distribute all the antiretrovirals. And there's been a bit of a challenge there, but this has provided another opportunity for another partnership, and we've been building a partnership with the Center for Excellence to work on this. In fact, they have come out to our site just a few weeks ago to discuss the needs that we're having, and they're currently working on a plan for our physicians to get the information that they need. So this is really exciting. Although it's been a slow process to begin with, it seems to be proving successful and helpful that will help each of us, the physician, the Center for Excellence, the PHN, and the client to meet our goals. So that's kind of my part.
Okay, so Kathy discussed basically the main steps that we use to establish our partnerships, but I'll just quickly rehash and summarize some of the primary steps that we took. So first, as Kathy mentioned, we identified the issue and vision. Using the epidemiology and then the experience of the nurses in the field, we were able to identify that in the East, clients have the most difficulty staying engaged in care. This is for a number of reasons, including issues around transportation, and then just the number of opportunities they have to engage with healthcare providers is less out there. So we decided that we would focus our initial work around re-engaging clients in the East, evaluated, and then based on what we find, we would look to expanding to the North and the South and doing similar work with the nurses and physicians in those communities. So in prioritizing, we identified some of the main treaters who are providing HIV care in the East, and we were able to identify 2 infectious disease specialists, or IDs, and 1 addictions doctor who are testing and treating the most HIV clients out there. So a lot of the work we do in terms of coordination and planning is done here in Surrey, in Fraser South. And as you can see, we have quite a large region. So as Kathy alluded to, we made sure that in building these partnerships, we went to the physician's turf. So we didn't set up teleconferences or ask them to come to us. We asked if we can approach them and meet with them. So I think one of the major selling points when we were trying to build this partnership is that we involved senior management. So we had our manager at the time for the Stop HIV ST BBI team come with us to this meeting, and she was able to speak to the excitement. She had been here for quite a while, so she was quite excited to finally be having these meetings with the physicians. And I think that the physicians liked to hear that we had a genuine interest in working with them and not and helping their practices grow, and also sharing the vision and the kind of shared goal that we would like to see client care improving. So that's one of the things that we kind of built or sold our partnership around, was that we want to improve client care, we want to see your practice grow, and we want to help you, support you in ways that you feel you need to be supported. So towards the end of those meetings, we clearly communicated what our next steps would be, and set up plans for follow-up, and I think we were good in keeping our promises, so following up when we said we would, and getting back to them with a clearly identified project plan and deliverables and roles that we had discussed in the meeting. So I'll just highlight some of the accomplishments that we've seen so far. And these are some of the accomplishments that we went into, or some accomplishments that surprised us, because we went into the partnership thinking that we would be focusing on client re-engagement, but we found that in developing these partnerships, we had a lot more successes come out of it than we initially envisioned. So one of those was building a more functional referral system between these primary HIV treaters in the community and our positive health services, which is our HIV hepatitis C center for specialty care. We have quite a few specialists there. So this was something that the physicians knew about, but many of them wanting to improve their ability to refer clients there for complex case management. Another thing that we accomplished was ongoing communication. So we've been able to meet with these physicians in the past. In less than a year, we've been able to meet with them each at least 3 times, which is, I think, quite an accomplishment given given the capacity and the caseload that they see and the amount of time that they have to do this kind of work. I think it shows that they're excited about the partnership and that they find value in it. As Kathy mentioned, we've been able to foster trust. So each of these physicians have given the nurses permission to act on their behalf in terms of doing outreach and connecting with their clients, following up in cases with different centers out there, including the Center for Excellence. We've found that it's not just us, whereas in the beginning it was us reaching out to them. Now it's them. It's a bilateral communication, and reaching out is coming from both sides. So we, as Kathy mentioned, the physicians have reached out to us to request the nurses' support for contacting cases and partner notification. And then we also have been able to have one of the physicians offer to help us with one of our grand rounds. He actually introduced us to the opportunity and put us in touch with Abbotsford Grand Rounds coordinator. So that's a presentation that we're having in September, and something that we never thought would come out of this partnership. So just quickly, I'll read through these quickly. What we've learned so far is that to build relationships far and wide, because you never know when you'll need to develop these partnerships more formally. I think one of the reasons we've had so much success is because the nurses had been in communication with these physicians over their years of practice, so whether it's long talks or meetings or just quickly introducing themselves. The physicians were aware of the team, and I think that saved us a lot of time in building the partnership. We were able to step into the shoes of the partner, so as we mentioned before, when we went to build the partnership, we didn't just talk about the clinical side of things or some of the things that the physicians, it might have gone through one ear and out the other, so to speak, but we spoke from the physician's perspective that this is something that's going to improve the care and the quality of care that your patients are receiving. Thirdly, we showed commitment. So as I mentioned, going to meet the physicians in their practices, bringing our senior management, and following up when we said we would. Flexible in terms of shaping goals together, so we didn't go in with a strict goal for the partnership. We kind of went into the meeting and discussed some common goals, visions, and objectives, and from there we went back and built the partnership, the plans and the aim statements. I think one of the things that we learned is not to focus too much on the numbers and the measurements in the beginning, and I think we did a little bit of that. And that may have been a bit overwhelming for the physicians early on. So moving forward, I think that's something that we'll consider, is that the partnership needs to be built and trust needs to be built before you can start focusing on things like evaluation and measurement. Sharing early successes, some of the things that we discussed previously, the physicians were able to call the Center for Excellence because of some of the advice that Kathy gave them and get some information on clients. And I think that the physicians were excited. They didn't know that they were able to do this, and it's a small kind of tangible thing that they can look at and say, because of this partnership, I've accomplished something that I didn't think I would have accomplished when we initially started. And it's a small thing, but it kind of alludes to some of the successes that are in store in the future. So I'll end there.
Thank you so much, Kathy and Jonathan, for your presentation. You saw some feedback about the really exciting work that you're doing. We actually got one question from Elena about, have you had any feedback from clients about being contacted?
That's a good question, because we actually haven't been able to contact the clients yet. So this sounds really funny, but we're still working on, well, actually there's one that I'm close to contacting, and I know her from before, and I think it'll be exciting to contact her. But we're still working on weeding out to find whether these people are actually lost to follow-up or if they're being followed by someone else. And so we're a little hesitant to call if they're being followed somewhere else. And so that's where we're at right now.
Do we have any other questions for our presenters from Fraser Health?
I just have a question or clarification. So has there been engagement with the clients and just no response as to how they felt about it, or that's still in the preliminary stages?
Okay, so that's still in the preliminary stages. So we're still trying to determine which clients are, have actually just moved and gone elsewhere, and so those ones we would take off our list and not try and contact, or that they truly are lost to follow-up. So we haven't really started that. And the other challenge is that the ones that are lost to follow-up, the contact information is vague and difficult, and many of these people are those that, may not have phone numbers, or they've changed many times, or addresses. We don't know exactly where they are. So we're kind of working on a detective sort of thing right now. We're just trying to figure out which ones we're focusing on and then how we're actually going to find those people.
There's another question about, did you meet any resistance from physicians, and if so, how did you deal with it?
There was a bit of resistance early on. I think that was born out of the fear that or not an understanding of what we were trying to do. At first, they thought that this was a project for the Center for Excellence, but when we were able to explain to them that this is something that is a Fraser Health public health initiative, and that our collaboration with the Center for Excellence is in terms of providing measurements and providing us the support to build this partnership and to make sure that it's successful and evaluate it. I think some of those fears and concerns were lessened. And as I mentioned before, because Kathy and our other bloodborne pathogen nurse had a relationship with these physicians to some degree, there was less of a mountain to climb in terms of building trust and overcoming some of that resistance.
While we're waiting, I think one question is being typed, but I have one question for you, for both of you. So you brought up the issue about engaging senior leadership early on in the process. I would love to hear a little bit more about it, what advice you would give others. And often I see it also the other way around, that senior leaders are in agreement, yes, we should do it, and there is a broad understanding, yes, there should be a partnership, but then that commitment often doesn't translate down to the frontline workers who are actually doing the actual work of the partnership. So any comments on both issues?
I think we were fortunate to have senior leadership that was willing to participate in the collaborative from the beginning. Mm-hmm. So they were there to hear from Clemens, yourself, Christina, and the rest of your team in the early learning sessions. So they knew what benefits being part of the collaborative held. In addition to that, they had an understanding that working with physicians and doing this client re-engagement work would essentially lead to improved outcomes, public health outcomes. So I think in the beginning we were able to put together a kind of a plan for what this client re-engagement work would do and how it would address some of the issues that we identified looking at our cascade of care. And that really was something that they were able to take to even more senior management and get approval for this kind of work. We spoke to our MHOs, and we kind of, there were some concerns about that this might be intruding on the physician's work, and so we made sure that our plan and our approach to partnership was not telling physicians what to do, but listening to their concerns and building the partnership around there. So although we had a plan going in internally, it's not something that we went into the meetings and kind of imposed on the physicians, but we had an idea, and our senior management had an idea of what the partnership may look like moving forward.
Well, again, a very intriguing and very well done presentation. I want to thank both of you for the tremendous work you're doing. And it was very great to see how you actually reach out to those and create those win-win partnerships. So thanks so much. We have about 3 minutes left, and I want to turn it over now to Christina, who will give us a quick update about some collaborative updates. And before I do so, I want to thank and congratulate our presenters, and I want to thank all the participants for this call today. I think this is an important topic, and we really believe that new partnerships are and will create the success of our collaborative, and we hope that one of the measurements of success is that these new partnerships are formed for the long run, and we wish our presenters well, and we wish all the participants very well, and hopefully we can come back to this really important topic in future calls or in our future meetings. Christina, do you want to give us a quick update about other steps related to the collaborative?
Thanks, Clemens, and thanks everyone for joining this call today. It was a really great conversation. I also want to specifically thank our speakers and contributors today, including Patricia Howard, Jen Hawks, Kathy Wall, and Jonathan Edwin. I also really want to thank Anna Prado, who does all the behind-the-scenes setup and keeps us organized. And finally, Clemens Steinbach for facilitating this exchange of ideas and piquing our curiosity today. This is such an important topic and something that underpins everything that we do. And I think the examples today are those that can lead us forward as we keep moving in our improvement journey. In the last few minutes of this call, I just want to direct your attention to some dates in September. The first is Monday, September 8th, and that's the next reporting deadline. Tuesday, September 9th is the next monthly teleconference call. And just a reminder that the new date is confirmed for Learning Session 3, and that's Wednesday, October 22nd. And we'll have more details forthcoming about that day. So thanks again for joining us, and I hope everyone has a wonderful Tuesday.
Thank you.
Thank you, everybody.